Raphael, you presented, a couple of very interesting cases, and one patient with very high PSA metastatic disease. And in your presentation, you said you were just treating him with ADT, and he responded very well. But is this still standard of care? I would like to ask the medical oncologist. So if this patient, PSA of more than 1,000, symptomatic bone met, what would your choice of treatment?
I believe it is not. We have to look at the patient, see the survival we expect for the patient, general condition. But if the patient has an expected survival longer than 2 years, I think just ADT is not enough, and we should add something else. I rather choose any AR targeted therapy, although we can say that if we don't have, or they are not available in our country, we can use chemotherapy.
Yeah. So now, this year at the ASCO, the Titan trial was presented with apalutamide. So now we have apalutamide, we have enzalutamide, we have abiraterone, and we have chemotherapy. So I think it's really difficult to choose the best drug. Do you have any preferences, or how do you choose the way you give your recommendation for the patient?
In fact, for most of my patients, I prefer AR targeted therapies, and I try abiraterone. Although it has to be available in the country. So, yeah. But if both chemo and abiraterone would be available, the only situation I see chemotherapy perhaps patients with a high aggressive disease, low PSA, high Gleason, but it's the only situation. In general, I would go to the best tolerable drug that could be the targeted therapy.